Hello and welcome to World Hypoparathyroidism Day. I am Patty Keating, your chairman for the Hypopara Association here in the United States, as well as your moderator for this evening. World Hypopara Day is a global event to raise awareness around our disease that affects an estimated about 200,000 people across the globe. I have to give a huge shout out to Parathyroid UK with Liz Glenister and her team. You guys really know how to throw a party. It was such a wonderful day being part of the event that I ditched my original opening for this evening and decided to share a few tidbits from today. I was inspired by all who participated and really enjoyed seeing people share their pictures, their stories from across the world. We had Tracy Lee from South Africa sending her love to fellow tinglers. Now, I think we can all relate to that as patients. Oana from Romania shared her beautiful 15-month-old daughter with her big brother. And Bob Sanders, our very own president, right here from the United States in the oil fields of North Dakota, enjoyed the party while he was working today. And little Connor, 4 years old from Northern Scotland, diagnosed January of 2022, still smiling, even though this is not easy. And the beautiful Ireland posted a sneak peek of their amazing new logo for Hypopara Ireland. We had so many of you post from the United States as well. Thank you so much for joining the party with Parathyroid UK, and Liz and your team. Amazing job. And the last thing we ended with was, of course, there was a post about put your animals on here too. We're waiting to see them because they are our support people as well, our support animals as well. So wonderful day. And I think what I took from that is that no matter what, we are not alone. And if it's even just for this day to feel that love that we felt as patients, it was a pretty exciting day. Excuse me, I'm getting a little up over it. We also would like to thank Ascendus for sponsoring this evening's event with the great support of the FIN team. This team has really spent a lot of time getting us prepared, doing the social posts, and really being able to get us ready for this evening. In addition to this event, we decided to host webinars all month long. So for the month of June, you will see a webinar that comes every single week, and it'll come from our different pharma groups, Amulet, BridgeBio, Calcilytics, and Ascendus. We're excited for each of these teams to share the latest with us and the things that they're working on. So there's going to be a link sent out every single week. So pay attention to our website, to our social media, so that you can join in. And of course, they will be recorded so that we'll be able to share them out with you guys. This evening's event is also being recorded, obviously, on Facebook Live. They continue, it'll be there for as long as you want to watch it. So tonight's theme is Be the Change. And what do we mean by that is we want to educate you, give you the information that's available to be able to advocate for yourself. What we know as HPA, we share so you can be the change you need to live your best life. So let me share with you how we're going to go through the next hour. I have a patient who will share her story with us, as well as two of our medical advisory board clinicians to share their perspective. And before we get started, of course, we have to have a few guardrails to be able to get us going. So tonight's discussion is really around general disease state. Our panel will discuss from their perspective, but they cannot give specific directional medical advice. As we know, a physician really needs to know the whole story and all the records that you have to be able to make a good directional advice for you. So we're going to keep this pretty global as we go through. We're not going to be mentioning specific drug companies or names of drugs or clinical trials, just so that we can provide a balanced perspective from HPA. And we also know that every patient is not the same, and what one person experiences may not be exactly the same as another. So no matter if you're new to this or you've had this for your whole entire life, we hope that you learned something this evening, that you take away something that will help you live the best life. We're going to do this for about 30 minutes. I'll moderate a panel discussion with these guys for about 30 minutes. Then we're going to open it up to some Q&A. If we don't get to all of the questions, or there's questions that we can't answer, we'll make sure to throw some things out on our website and our social media so that we're able to answer what you have asked us. So we also, at the end, have some pretty exciting announcements for you. So we do hope that you have your favorite beverage in hand and that you are ready to get started. So I want to first introduce our Barry Vapnik. She is our director of PR, and you have seen her playing around on social media with you, answering things and helping you out. She's done an amazing job working with the FIN team for the hypopara community, and she is a patient herself, and she has offered herself out this evening to be vulnerable and share her story. So Barry, share a little bit about yourself and hypopara.
Okay. Hi, everyone. Thank you. Thank you, Patty. Thanks, everyone, for joining. My name is Barry Vapnik. I was diagnosed with hypoparathyroidism at the age of 25 in 1998, following a total thyroidectomy for Graves' disease. My first calcium crash happened shortly after surgery, and I actually immediately became pregnant with my daughter and had her 9 months later, and my son 2 years after that. So I didn't really feel the actual ramifications of having hypoparathyroidism the first few years, as I wasn't really that symptomatic until I had a second calcium crash in about 2005. This condition has affected my life both personally and professionally, and has really become my full-time job managing my hypoparathyroidism.
Thank you, Barry. And again, thank you for your vulnerability and sharing your story. We look forward to hearing more about that as we go through. So let's hear from Dr. Rubin. Share with us a little bit about, Dr. Rubin is from Columbia in New York. Share with us a little bit about yourself, maybe some things that you're working on and how you're related to the hypopara community.
Yes, good evening, everyone. I'm Ms. Shayla Rubin, and I'm an endocrinologist at Columbia in the Metabolic Bone Unit. And I've been involved with hypoparathyroid patients since 2004, both taking care of patients in my clinic and being involved in research studies which look at the different manifestations of the disease in terms of biochemical derangements, quality of life effects, bone effects, and how different treatments can help to address some of these concerns. I've also been involved with the HPA on the medical advisory board and attended conferences over the years. So I feel very deeply connected to the hypoparathyroid community, and I'm privileged to be here tonight to join this.
Thank you so much. And we're so grateful for you. You have been an active member and at our side every minute that we needed. So thank you so much. And Dr. Kohlmeyer is here from Spokane, Washington, to talk to us tonight. So share a little bit about who you are and what you're working on and how you're related with hypopara.
Thank you, Patty. Yes, I'm on the West Coast and very honored to be part of this. I'm on the medical advisory board as well for the Hypopara Association, and I'm an endocrinologist in clinical practice and have the honor of doing research both in hypopara and osteoporosis, and have learned so much from my patients, really more from my patients than I ever did in training. And really am hopeful for the future. And I just, gives me so much joy to see my patients doing better. So that's what our goal is tonight, to empower the providers and our patients as a team to really conquer this condition and feel your best and do as much as you can all the time, like we all want to do.
Absolutely. Thank you so much. And we're so grateful to you as well, as you lead our medical advisory committee. So we really do appreciate that. So can we go back Barry, and I'd like for Barry to describe a little bit more detail about your experience with the hypopara as you've gone through.
Okay, well, when I was initially diagnosed shortly after surgery, I really thought I was the only person that had the condition. I thought that after having my thyroid removed, I was going to have this, wonderful, great life, feeling healthy all the time. And little did I know, I developed this rare disease called hypoparathyroidism. So I really felt alone, and I didn't have much knowledge about the condition. I had my second calcium crash in 2005, and even my doctors didn't understand how this affects so many systems in my body. I've developed stage 3 chronic kidney disease, anxiety, depression, elevated heart rate. I've developed a host of many conditions because of my hypopara. I've been lucky enough to have tried a few different treatment options. I was on standard of care for years. I tried a PTH replacement for a little bit of time. And it's basically having hypopara. It's a roller coaster. There are no 2 days are the same. I look at it as a good day as a win, and a bad day as well. There's always tomorrow. I could try again.
Absolutely. Thank you so much, Barry, for sharing that. And so, Dr. Rubin, when you think about the actual parathyroid and the calcium and all these things, can you share with us a little bit more in depth with the parathyroid? Because a lot of us don't know, right? Like we may have not known when we got, when we went through the surgery, what the heck is a parathyroid? So can you share a little bit more of your experience with that?
Sure. So we have 4 parathyroid glands, and they're really tiny, each the size of a pea, located right next to the thyroid, 2 on the right and 2 on the left. They make parathyroid hormone, and parathyroid hormone controls how much calcium is in the blood. So the hormone will reabsorb calcium that's getting filtered through the kidneys so that not too much calcium is getting lost out in the urine. The hormone will also cause the kidneys to make activated vitamin D, which then can absorb calcium from the intestine. And the hormone can also cause calcium to come out from the bone and go into the blood. So if somebody doesn't have enough of the hormone, they'll be losing too much calcium into the urine. They won't be absorbing the calcium in their intestine, and the calcium will remain trapped in the bone and not able to come out into the blood. So people then feel unwell because of the low blood calcium. That means that their muscles and nerves are too twitchy. So they can have numbness and tingling in their fingers or lips or toes. It could even lead to spasms. And also, perhaps most distressingly of all, it can lead to brain fog and feeling not like themselves cognitively.
Absolutely. Okay, very good. Thank you. And Dr. Kohlmeyer, anything else you would like to add to that around the experience and what patients experience and everything, and what with parathyroid and calcium?
Yes, thank you. To add to what Dr. Rubin and Barry have said, the parathyroids really are your calcium glands. That helps me remember and to explain it to my patients. And calcium and vitamin D are both hormones, which is one of the reasons why in endocrine, because we're always about the hormones, that we're so interested and have spent so much time trying to understand why calcium level has to be at a certain point in order for nerves to work and muscles to work. And so in addition to what Dr. Rubin said, the variability of calcium and symptoms is just unbelievable. So people can have calcium so low that their larynx spasms, they get laryngospasm where they can't talk or breathe, feel like they can't breathe. It's very frightening. Or if it drops very low, they can have a seizure. And some people aren't told that there's that risk. On the other hand, what somebody might call mild can last all day, tingling and a numbness. That is not mild. So I think I'll end this part on what Barry said, that it's a full-time job. I feel that living with hypoparathyroidism is a full-time job, and people become so tough and deal with these symptoms, but we really want to know about that as a provider. And we don't want you to have tingling and cramping all day and be afraid of laryngospasm or seizures. And that's why we want to help keep the calcium in a safe range.
Yeah, that's a really great point, because we as patients, I'm going to say me, not we, it becomes normal. It becomes part of your life, like the tingling, it's one of those days, or, it happens. So, and for you to say the physicians want to know about that, like we're not just complaining or, being crazy or whatever. So it is a true symptom that we need to be able to share. So thank you for it. It's almost like a validation to a patient. So very good. All right. So I want to dig a little bit more into the symptoms. We've touched on a few, the tingling and these sorts of things. But Barry, can you talk a little bit more about a really great day and a really tough day?
As I said, every day is different, and unfortunately, hypoparathyroidism doesn't respect plans, whether it's a holiday or a family gathering. It just kind of acts up when it wants to. And those famous last words that people say, just take a calcium and you'll be okay. Not always the case, in my opinion. So on a good day, well, I've had some great days. At one point in my life, I was on a PTH replacement, and I was able to bike ride across the Golden Gate Bridge. And I am not an athlete by any means, so that was just a huge win and one of the best days of my life. But a good day is just getting up and going to work, which I've been able to do part-time, which is nice. And a bad day is tingling, a lot of tingling, a lot of numbness. If my calcium is low, if my calcium is high, I am constantly nauseous, just nauseated, living on Zofran. I also get these horrible headaches when my calcium is either high or low. Sometimes I don't know if it's high or low. It's baffling. I know that having this disease has really affected my mental capacity. I've always considered myself such an extrovert and outgoing, and it's really turned me into an introvert. It made me depressed and gave me anxiety because I worry about a calcium crash. After having a calcium crash, I get scared I'm going to have another one, and I don't want to have another one. It's really affected my ability to think clearly. Unfortunately, I've acted impulsively. I've been triggered by some personal things in my life that it really just made me react in ways that I would say a normal person wouldn't react. And all of those times that I've had these moments, I call them blips, it was always when my calcium was low, and I try to control it, but sometimes I'm just triggered, by these things that are happening in my life. So it's scary, and no 2 days are the same. But as I said earlier, a good day is a win.
Very good. Thank you so much for sharing that. I know it takes a lot of times we don't share all our symptoms, right? We just want to kind of keep it and we just do our thing. And we appreciate you sharing that. So Dr. Rubin, I'm sure you have a lot of patients with the same type of symptoms, but is there anything that you can think of in addition to that, or very specific around the symptom part of everything with hypopara?
Sure. Yeah, I think Barry very powerfully described the symptoms that patients have. I think it can be, incapacitating sometimes. Just yesterday, a patient told me that she had to drive her son to the doctor, but she was too scared to do it because she felt like she might be having a calcium crash, and she thought it just would not be safe for her to be driving. So I think the physical symptoms have a very debilitating impact on being able to perform just daily life functions. And of course, the cognitive symptoms of feeling that one can't find the right word or remember also is very incapacitating. And I think that all of this is connected to feeling anxious, as Barry described. I think patients also worry about the long-term consequences of the disease. How will this affect my kidney function, my vascular health down the road? And I think, as was alluded to, sometimes doctors, just don't know enough to really understand that this could be all part of hypoparathyroidism, and might dismiss the patients and say, well, your calcium is fine, so you're okay. I've had patients in college who had to drop out of their semester, patients who weren't able to continue at their work or couldn't independently take care of their children. So I think it's really underestimated the type of harmful impact that this can have on people's lives.
Yes, absolutely. Thank you for sharing that. And Dr. Kohlmeyer? Got a few additional symptoms, I'm sure, over there.
Absolutely.
Yeah.
So as frustrating and frightening as that is, one of the things that is really positive is the research, and I think the medical community is understanding quality of life and hypoparathyroidism and how there's a direct relationship, and that was missed, I think, for years. And our patients will tell us that they would see somebody and look beautiful and their labs looked okay, and all of their story wasn't absorbed by their provider. So I think that's really helping us do a better job for our patients. The other thing that's really important is to have a calcium safety plan. And, it's almost like a diabetic that has to be careful their blood sugar doesn't drop and they have sugar with them, or maybe some glucagon, or an adrenally insufficient Addison's patient. Maybe they have, some steroid tablets or a shot they can give themselves. It's harder with calcium because you can't just give yourself a shot of calcium. I wish, when you're camping up in Upper Priest and you think your calcium's low, for example, in Idaho. But to have a medical alert bracelet or necklace, I feel better as your provider if you do. To have it in your phone, to have a card, and the Hypopara Association has cards that you can, that we've worked hard to make them simple and readable. And then to have that plan yourself, have a family member, a friend, an advocate, a navigator, someone that's going to come with you, drive you, know where the emergency room is. And then just for every day, not thinking about the worst all the time, to say, I want to do more this day. I'm going to go on a hike. I'm going to prepare for that. Take more calcium, or make sure you have it with you. Or if you do get a GI bug, or you have diarrhea, or you have COVID, or you're getting a colonoscopy and you need a prep, that's a risky day in time, because you're not absorbing your calcium and active D. And to proactively prepare for that, so that it relieves, I think it relieves that worry. I hope it does. And then to be ready and to try to prevent the low calcium.
Absolutely. Thank you so much. And that detail of being prepared and ready and knowing is so important for all of us to really think about and be prepared for. So let's talk about the diagnosis, right? So a lot of times, people may be having these symptoms and they just don't even realize. So sharing with their physicians, like you said, is critically important. So Barry, share with us a little bit about how you actually got diagnosed with hypopara.
Okay, well, I was diagnosed a few hours after surgery. I remember I was in my hospital room, and all of a sudden, half of my body went numb, the whole left side of my body, my face. I couldn't speak. I couldn't lift my hand. I thought I was having a stroke. And the doctors immediately diagnosed me with hypoparathyroidism. I wasn't given any background on this condition. I just, knew going into surgery, oh, you'll need to take a thyroid pill, every day, replacement. So basically they said, oh, now you'll have to take calcium in addition to your thyroid medicine. I became pregnant, as I said, basically immediately after I was diagnosed. So I didn't really feel, I think when you're pregnant, you don't really feel the symptoms of hypopara. So I guess I was feeling okay for the first 3 years because I had two babies back to back. And it wasn't until 2005 that I found out that I have chronic kidney disease and a host of other medical conditions because of the hypopara. I was always taking my calcium all at once. I would take 20 pills all at night before I went to bed. I didn't know you were supposed to separate this throughout the day. I wasn't educated. My doctors weren't educated. So finally, I found another endocrinologist who was willing to learn with me. And we broke up my calcium into doses throughout the day. And eventually, in about 2015, she told me about a new parathyroid treatment that she heard about at an endocrine conference. And I started it because I was like, oh, great. And it was wonderful. That was when I was able to bike ride across the Golden Gate Bridge, that I'm so proud of. But I thought that was a cure. I didn't realize that this disease, still at that point, I didn't realize that this was for the rest of my life. And I, had to go back on standard of care, and I just keep trying to hide my anger that I have for this disease. It made me very angry that I should be this vibrant person, and I'm not. But it's been a journey, and I'm lucky enough to have a great team of doctors because I have self-advocated, and that was really, how I found my answers, and through the Hypopara Association.
Absolutely. Thank you so much for that vulnerability again, and sharing the detail there with us. We really do appreciate that. Dr. Rubin, share with us a little bit about, as you see patients in your clinic, like what types of things how do you go about diagnosing hypopara?
So to make the diagnosis, we need to see a low blood calcium along with a low or inappropriately normal parathyroid hormone, because if the calcium is low, the appropriate parathyroid hormone response would be to go up. And if that's not happening, that's the biochemical hallmark of the disease. And we want to see on two separate occasions, at least 2 weeks apart, that there's a low calcium and a low or inappropriately normal PTH on the same blood draw. And that really is what would make the diagnosis. Other lab tests would also be consistent or confirmatory. Patients usually have a high phosphorus level also. Patients also almost always have a high urinary calcium as well. So those would really be the clues that would make the diagnosis for it. It could be that after surgery, your surgeon might tell you that you have the diagnosis, but it would really be the endocrinologist who would help you figure out exactly how to manage it, when your labs should be drawn, what your treatment regimen should be like, and how you can best care for yourself.
Okay, thank you so much. Dr. Kohlmeyer, how do you diagnose your patients out there on the West Coast?
That's perfect. As Dr. Rubin said, I think that in endocrine, our stethoscope are your lab results. And so we're going to ask you to do labs, not once, not twice, usually at least 3 times. And with hypopara, you know that you're getting labs every 3 to 7 days sometimes when things are more stable, which we haven't heard the word stable yet. It's every 3 to 6 weeks, every 3 months minimal. And then it's the combination of labs. So if your calcium is, let's say, less than 8.6 in the low normal range, and your parathyroid hormones 15 to 20 or lower, so it's not starved, as Dr. Rubin said, but the combination of a low calcium and a low PTH is very suspicious for hypoparathyroidism. And we're measured a few times to make sure if you've had anterior neck surgery which about 3/4 of our hypopara patients have had. That's why they're hypopara. Then now the new guidelines suggest that it's a year after surgery when you're definitely defined as having chronic hypopara forever. Will that change in the future? I think one message that we all talked about before we started is that we don't want people to test their parathyroid, to taper down so low that it's dangerous, to see if you can wake up your parathyroids. You want to work with your provider. And, sure, you're always going to be adjusting your calcium, but you want to do it in a very safe way, and your active D, your prescription vitamin D. But again, it's the combination of the labs. And the other thing I think I'll add is that within, a day or two of surgery, your surgeon or your endocrinologist will check your calcium and parathyroid. And if your parathyroid level is over 10, which is still low, you're much less likely to have hypoparathyroidism long term. But within that short period, if your calcium's low and your parathyroid hormone, your PTH levels less than 10, then we're more concerned, and we're going to watch you very carefully.
Okay, thank you so much. And I just have a question. So after, you're diagnosed a year or two, do you still check the parathyroid levels years later? Is that a common practice in continuing diagnosis?
It isn't usually, because once the disease is determined to be permanent, it's really highly unlikely that the parathyroid hormone level is going to come back up. If there was a clinical change, if patients seem to be developing high calcium levels, then of course it would be appropriate to check the parathyroid hormone, but it's not, in my practice, part of the normal monitoring, over the years.
Okay, very good. Thank you so much.
And I
All right.
absolutely agree with that. And Patty, I just want to add that, about 7 to 8%, and we know some of you are there listening, never had surgery, and that this is genetic, or we use the word idiopathic when we're not sure, but maybe you haven't had anyone else in your family and you haven't had any genetic tests. And we assume then that your parathyroids aren't working. We assume that you have them, but they're not working. And right now our treatment is the same, but in the future it might be different. We might be able to wake up those parathyroids that you have if you haven't had them removed surgically. And maybe there's different levels of risk depending on why. But I think what Barry's explained and what we've recognized in our many patients is that they're so variable, whether they're post-surgical or whether they're genetic. It can vary even within the same family. And that's why we need you to check your calcium levels a lot and to be really cautious about making sure you're not in a situation that's going to increase the risk of you having a low calcium level.
Very good. Thank you. And then the other question is around the magnesium. I think I had asked somebody about, is it in conjunction with the calcium? Is it a typical thing that you would use for diagnosis or more for symptoms? Would either one of you share?
So it is common for patients with hypoparathyroidism to have a low magnesium level. And this is because parathyroid hormone has some control over magnesium. The biochemical structure of magnesium is similar to calcium. And with a low magnesium level, that can make the low calcium worse. So it is important to check the magnesium level in order to see if somebody needs to be taking magnesium, which is pretty common. So I don't think it's a test we would use for diagnosis, i.e. the magnesium level, but it certainly would be something we would measure regularly as part of the management and prescribe magnesium if needed to keep the level in the normal range.
Very good. Okay.
And I think I can add to that by, there are some conditions where you would lose more magnesium. So people on medicines for indigestion or reflux, so the proton pump inhibitors, we call them, the PPIs, you just lose more magnesium and you're going to have to be more cautious with that. Alcohol use usually is related to a low magnesium. Any other reason for malabsorption? I don't specifically know about celiac or ulcerative colitis or Crohn's, but anything where there may be GI losses, we're going to worry about losing everything, not just magnesium, but calcium. And we know, and we haven't mentioned this yet, but this is an obvious, when you're trying to take calcium 3 or more times a day, maybe even 6 to 10 times a day, if you have each dose smaller, maybe calcium citrate, I think we'll talk a little bit about calcium later. That's so hard to tolerate. So a little bit of magnesium with the calcium helps, but once you're up over 600-700 milligrams of magnesium a day, you're going to have the opposite effect. It's going to backfire, and then you're going to have loose stools and diarrhea. So that balance, like anything else, is such a challenge with hypoparathyroidism.
Absolutely. Yeah. Thank you very much for clarifying that. And then, so I'm going to give you guys one more question to sum everything up, and then we'll start with some Q&A. And it's really based around, for Barry, how has this really impacted you? I know you talked a little bit earlier about it, but share your kind of closing thoughts around hypopara and living with it.
Well, thanks, Patty. Could say that when I was diagnosed, it was my 1-year wedding anniversary, and I had a great job in marketing and my whole life in front of me, and everything just changed. I was often not able to be present with friends or with family. People thought I used my condition as an excuse to cancel plans. They didn't realize it would just act up. My daughter is now pursuing a degree in healthcare, being a chiropractic school, because she saw my quality of life, how poor it was. And it really, she empathized and didn't like to see that, and wants to help people. And I'm so proud of her that she was able to look at this bad card I was dealt, and her, not that she could cure, but she can help someone's quality of life. But having hypopara, it did affect my marriage. I got divorced, and it was just a very dark time in my life. Really affected my relationship with my son. My son, he's my baby. I'm 21, but I was always super close, and he would come with me to doctor appointments out of state to see his favorite teams play in sports, and it affected him. Our relationship really suffered after one of my crashes, and he was home a few weeks ago, and he said to me, he's like, "Why are you always pretending everything is okay? Why do you put this mask on?" And I just tell him I'm trying to protect him. I don't want to burden. I feel like I burdened everyone in my life with my illness, so I just try to brush it off and make it, seem like it's no big deal. But he notices that, and he said, "Just talk about it, be honest." And so really, hypopara has affected just so many aspects of my life. I never thought I would be where I am right now, but that's also a good thing, because I've learned to find hope. I've learned to turn obstacles into opportunities. I've learned to be my best advocate, to find answers, even when doctors were saying, "Oh, you're crazy." I had to find the right doctors. I had to make an effort. I do things such as acupuncture, just little things to just help me, whether it's helping my mental or my physical. I don't know. Every day I try to be a little bit better than I was yesterday. And I'm trying to learn from some of the mistakes that I made, and just trying to, spread hope, and just,
We're
with all these
super proud of you, Barry.
Thank you.
You are really doing a nice job advocating for yourself, which then advocates for all of us in the hypopara community. So we couldn't be, more grateful for your vulnerability and you sharing today. what you've gone through. I'm sure there's a lot of people that are watching that can really relate to that. So we really do appreciate you sharing that. Dr. Rubin, do you have some closing thoughts around the hypopara, your patients, how to continue on?
Yes, I would say my first message is to feel validated. When patients come to see me, they just think so many of their symptoms are, like, oh, I'm getting old, so I'm not thinking clearly. Oh, I'm just a very anxious person. I'm just someone who really gets tired easily. And I think to feel validated that this is really part of the constellation of symptoms of the disease, and also that you're not alone. I think because it's such a rare disease, patients just, can feel isolated with it. I think to feel like a partner with your doctor and to strive to achieve that, I think medicine is moving more towards patient partnerships. And you and your doctor should be a team against this disease. And it's very common for your doctor just not to know enough about this. And I think you should feel confident to ask your doctor and even educate your doctor about what this disease looks like, because that's part of getting the best care possible for you. And I'd like to give a message of optimism for the future. I think there's a burst of research activities and interest and promising therapies. There's PTH therapies that really seem to alleviate so many of the symptoms and complications. There's studies going on with parathyroid transplantation. There's also studies going on with using stem cells to make them turn into parathyroid cells. And that's really a hope for a cure. So I think when we look to the future, we can feel in the pipeline and on the horizon that there is a reason to have hope for living with this condition.
Thank you so much, Dr. Rubin. What a wonderful message. Dr. Kohlmeyer, share with us your words of wisdom for our patients before we go into question and answer time.
Barry, that was so inspiring. And Dr. Rubin, I couldn't have said it better. It's just so fantastic. I'm just going to listen. And thank you all. And I'm looking forward to the questions. And I love the message of hope. I'm so excited about research. And I know as a provider involved in research with hypoparathyroidism, there's no other condition where patients don't feel themselves and get their lives back faster. And to be part of that is so inspiring for me. So I'm so grateful for all the people that we can't see that we know are here.
Right.
And I know that you're going to feel better.
Very good. All right. So let's start with some questions here. For the doctors, my son is 2.5 years old, and I'm fiercely devoted to advocating for him with suspected ADH1. I'm at the best hospital in my state, but there still is a lot for our healthcare team to learn. How can we best encourage our providers to better understand this condition, learn more beyond basic training, and get involved? Would like to ask for additional support in the best way possible. So who would like to share a little bit about that?
I can take a try. I'm sorry for all that you and your son have been going through, and cannot even imagine the struggle. ADH1 is such a rare disease, so I'm sure it's hard to find providers who are knowledgeable about it. Fortunately, there is a burgeoning interest and research and treatment for it. As you probably know, the disease means that the sensing mechanism for calcium is not sensing appropriately. There is a study that's looking even in young children to follow how they do in this condition. And there are studies going on in older children and adults with a medicine that can specifically correct the imbalance in the calcium sensing. I know your question is about how to educate your providers, but I even wonder if there are disease education tools that could be provided to you and your provider based on all this new research that's going on in this disease.
Very good. Thank you so much. All right. And then the second question was, are there different levels of hypopara? Dr. Kohlmeyer, you want to take a stab at that one?
Absolutely. Yes, I mean, people have partial hypoparathyroidism. We don't label it that because we're worried about the highs and the lows, but we suspect it when you don't need as much calcium or as much active D. Most people need at least 0.25 micrograms of active D twice a day. And we've been calling it active D maybe for 5 to 10 years now instead of calcitriol, rocaltrol, or 125 dihydroxy vitamin D. For those are all the same thing for that exact obvious reason, because calcitriol and rocaltrol sound like calcium. And active D, as Dr. Rubin explained, is made from parathyroid hormone, from the D that you make in your skin from UVB light, or that you take D2 or D3. It's activated with 1-alpha hydroxylase and parathyroid hormone into active D. So that's what we give you when you don't have parathyroid to make it. And so if you had partial parathyroid function, then you might not need as much. Maybe you can get away with 1 a day. Maybe you only need 2 calciums a day. Most people need at least 3 or more. And as Barry pointed out, very important to split it up because you only absorb at most maybe 500 milligrams at a time. I think the other thing that is part of your question is if people have partial parathyroid function and we don't keep measuring the PTH, as Dr. Rubin said, maybe their urine calcium isn't as high. And so if your urine calcium isn't over 350 milligrams or 800 to 1,000 that I've seen sometimes, then we don't have an explanation. At least a third of our hypopara patients or more spill calcium because they don't have parathyroid to hold it on at the kidney. And so I think that the treatment's the same right now, and the symptoms can be just as terrible, it seems, if you have partial or complete hypoparathyroidism. Because it's all about your calcium level is what we feel and the neuro and muscular response to that calcium fluctuation.
Very good. Thank you. The next question I'm actually going to take, and it says, is there a support group within the association for our families? They almost have it worse. And we do recognize that all of us as patients, our caregivers, sometimes they take it on for us as well. So one of the things that I can tell you that as a organization, we are going to be branching off. Loretta Gully is leading that piece up where she is working on diversity and inclusion and getting these different groups from across the United States and potentially throughout the world to be able to work with different people. So stay tuned for that. We have acknowledged that and we'll be working on that. Let's see. I'm having a hard time finding a doctor who is knowledgeable. How would you recommend I go about finding an expert? So I'll take part of it and then I'm going to pass it off to one of the doctors to see if they have any additional. So we do have a list of experts on our website and we are working very hard to update that through some different channels. And certainly if you have a doctor that you absolutely love and they are knowledgeable and willing to learn and wanting to participate, please send an email to admin@hypopara.org and we will add them to our list as well. So Dr. Rubin, Dr. Kohlmeyer, any thoughts about how they could potentially find an expert in this? From your perspective, do you think, is there anything else that they can do to find somebody to help them?
I think the network that you have set up at HPA is probably the best route. There is always word of mouth. And I think any doctor who focuses on bones, which oftentimes is osteoporosis, might be familiar with colleagues in the field who have a special interest in hypoparathyroidism. So that could be a way of, just asking through doctors that But I think the HPA grapevine is really probably the best.
Absolutely. Very good.
And to add to that, I
okay.
think that with virtual medicine, hopefully it doesn't disappear now with a lot of new rules post-COVID, but I think it really helped the subspecialists help our endocrinologists, help our primary care. I have a lot of primary care providers in our community that know a lot about hypoparathyroidism. The companies are doing a fantastic job increasing education, and the companies have different websites, both for providers and for patients. And I think that all of that's going to really help. And, not to feel like it's the wrong thing to get another opinion or to go to another doctor. And to let everybody communicate and be transparent, and everybody wants the best for you. And so if you want to feel that you want another opinion or want to find somebody that knows more about a specific condition, we absolutely support that. And one of the important points that you just brought up, both Barry and Patty, is the loved ones and family members and the frustration and stress around everybody around you. And we know that when you feel better, they feel better, and everybody's anxiety and stress level goes down. And it might be your family member that's saying, could we see somebody else? Or, can I take you to somebody else? And you feel you don't want to burden them with another appointment, but you're going to do it for them. And, it's that teamwork that really helps.
Yes, very good. Thank you. A couple questions here. How much calcium is safe to take in a day? I don't know if we can or should answer that, but if you guys have anything that you'd like to share around that piece of it.
I think it's really how much the person needs. So, I would say a typical dose for a hypoparathyroid patient might be a total of 1,800 milligrams a day, but certainly there are patients who need much more than that. The really hard thing in terms of whether it's safe or not is balancing it with not letting the urine calcium get too high, because oftentimes you'll take enough calcium to alleviate the symptoms, but then pay the cost with the urine calcium increasing. So that's kind of the safety barrier, really, in terms of how much calcium is safe, But if somebody has that calcium requirement, it could be very dangerous, not to take enough. So I don't think there's a hard and fast limit. I would just say to keep an eye on the urine calcium, really.
Very good. Thank you.
And I think to add to that is when you're taking active D, that is helping you absorb the calcium. And it's not really something we want you to take extra of, like you might take a calcium if you're low, and it depends differently on every patient and provider. But if you're asked to take a thiazide diuretic and you don't have a contraindication because you could be allergic, it's a diuretic, it can raise blood sugars. But if it's tolerated and balanced, it can lower urine calcium levels by 40 to 70%. So a lot of hypoparathyroid patients are able to take the calcium they need, split up many times a day, ideally less than 2,000 milligrams a day, but it can be as high as 6 to 9 grams a day. That's rare, and very hard to tolerate. But then if the thiazide diuretic and active D are balanced, then we're watching the urine calcium to keep it in a safe range. The reason we care about that seems obvious, but studies have proven that the higher the urine calcium is, the worse it is for the kidney. And that has been shown, so that it can either turn into stones or it can calcify the kidney in ways that an ultrasound can pick up much before the kidneys start to slow down. And that's why it's so important to have this balance and to get your labs a lot and to do more 24-hour urines than you ever thought you'd have to do. But that's such important information for us.
Absolutely. Thank you. And I'm going to go with one more question, and then I'm going to share some announcements that we have. This one's interesting. How do we deal with getting help when the conditions share some of the same symptoms? That's always a tough one, right? So when, how would you what would you recommend to a patient with that? Dr. Rubin, you want to share first?
Meaning that it might share symptoms, let's say with hypothyroidism.
Yes.
Yeah, it is very tricky. And I guess one would work, to kind of do a process of elimination. So if somebody's thyroid hormone levels are normal, but yet they're still suffering with symptoms of brain fog, that could very well point to the hypoparathyroidism. If there's some improvement in the hypoparathyroid symptoms with slightly higher calcium levels, that would also point to it being a result of hypoparathyroidism. So it can be very tricky to sort it out. And I think you might need a little bit of a diagnosis of excluding other possible confounding issues in order to be able to tease that out.
Yeah, it's tough. Go ahead, Dr.
The
Perlmeyer.
reason that's such a great question is that 2 points. When you take a lot of calcium because you have to, you don't absorb other things well. And so very often thyroid levels are all over the place. And it probably is both conditions, your calcium fluctuations, and all of a sudden your TSH, instead of between 1 and 3 where we want it, it's 10 or 30. And we have to check thyroid a lot. But if you're having lightheadedness or palpitations, just as Dr. Rubin said, we don't want everything to be blamed on your calcium, because then we might miss something else. And we all tend to do that. Well, it's your calcium or it's your thyroid. And so together with your provider, we say, okay, we're going to make sure we're not missing anything else.
Absolutely. And I also think from a patient perspective, journaling and knowing when different things happen with your body or you're being triggered by something, to journal it so that you understand and you can share some of those things with your doctor as well. So, all right, we have about 4 minutes left. So what I'm going to do is I'm actually going to go through some announcements here and let you guys know what we have going on. I have a few pretty exciting things. So we've been working super hard behind the scenes to make things happen. And I wanted to give the biggest shout out to Michelle Reyes. She's our vice chair for Hypopara for her fantastic work with the Ashfield team on creating a brand new website for us that we're going to be rolling out in July. So that, we got a little sneak peek of it and it's pretty exciting. We want to be able to inform and educate you guys as much as we can. So I think you'll find this a delight. So stay tuned for teasers for that. As a HPA, we're continuing our work with Rare X, with Global Genes and Nord. We're going to have our booth again at the Endocrinology Conference in June. We're going to be in ASBMR with our booth in October. We have submitted for a PFDD and hope to be in person in front of the FDA in February. So we're really excited about that. And I've been working hard on trying to get these educational events together. So we'll be hosting that over the next, like I said, once a week for the next month. So you'll be seeing some information about that. There's been some teasers already put out on our site for social sites. And some really super exciting news that we went back and forth this year. What are we going to do? Are we going to be virtual? Or are we going to be live? When are we going to do this? How are we going to do this? Are people going to come out? Or are they not going to come out? So here's what we've done. We have made a decision. We are going to be live in Virginia. We're going to be right near Dulles Airport, easy access in and out for people to come. We are going to limit this event to 100 people because we are just getting back out into the world. So we're going to have an in-person conference event for 100 people in November 3rd and 4th, so you can pencil it in. The details are still being worked out because, we're still 6 months out from that. So look for some teasers coming out. Look for registration. Will probably open about mid-July for that. These two lovely ladies, the doctors on here today, have committed that they're going to be live in person. So we're excited about that. I think we have 8 other ones that will be in person for that day. And an amazing thing to add to that is HPA is going to be able to help provide scholarships for those in need for some of their travel expenses. And again, more details to come, but we are just beyond excited to be able to have true hypopara hugs with each other and really just be together for a couple of days for the 100 people. And you know what? Hey, this works out. We'll make it even bigger next year. We just need to get back out into the world. We will be videoing the ones that we can, so that we'll be able to put that on our website afterwards for the people that cannot travel to us to attend. So we wanted to share that with you because we're pretty excited about that. So I wanted to leave you with this. And again, stay tuned to our social media, our website. Our new website will be live in July. So right now it's still a little under construction, but you can get your information that you need there. But I want to leave you with this. Our disease is not easy. We didn't have a choice in having it. We didn't create it. We didn't cause it to happen. There is hope. There is huge hope right now for treatments ahead. There's life to live. Even if it isn't the life how we wanted to live it, we have to live it. Each day is the only day that will ever be. That day will never come again. So let's do the best we can to live, enjoy the moments, enjoy the minutes that you're giving. And we wish you much love to you all. And thank you so much for joining. Take care.